Great. Thank you very much, everyone. I think there'll probably be more people coming in. I wonder if there was just some issues with everyone today with regards to connectivity and weather. I know I've had some power going on and off in my place as well today. But it gives me great pleasure to introduce a friend and colleague, Dr. Guillaume Marquis. He is an assistant professor and interventional cardiologist at the Montreal Heart Institute and Université de Montréal since 2020. He's a junior 1 FRQS and completed an MSc in biomedical sciences. He completed a clinical fellowship and interventional cardiology fellowship at University of Montreal and then Duke University. That's actually where I intersected with Guillaume. He did his interventional training there in addition to a research fellowship. He's extremely well published, being the primary author or co-author on papers in the New England, JAMA Cardiology, JAMA, JACC, Circulation, and the list goes on. He's the associate editor of CJC, and his main research interests revolve around antithrombotic agents, acute coronary syndromes, prevention of contrast-induced nephropathy after PCI, and innovative clinical trial methodology. Also, he does a lot of CrossFit and really puts all of us to shame with regards to his athletic endurance. So there we go. Dr. Marquis, I hand the baton off to you. Thank you so much for taking the time to speak with all of us today.
Yeah, sure. Yeah, thanks, Abhinav. Thanks for the opportunity. I was asked to talk about my trial. I run a randomized trial called the NEPTUNE trial. I call that a pragmatic, adaptive, and patient-oriented trial. So the purpose of this talk, well, I'm going to talk briefly about the trial, and the second half of the talk, I'm going to focus most on these specific design elements. So pragmatic design elements, adaptive trial elements, and patient-oriented trial element. I'm going to define the concept and then discuss how it was applied in the NEPTUNE trial. And then we can I want this to be interactive, of course. We can discuss about all of this group. These are my disclosures. I have nothing relevant to this, and the NEPTUNE trial is not sponsored by the industry. So just a little bit of background about the contrast-induced nephropathy after coronary angioplasty or coronary angiogram. The incidence rate of contrast-induced AKI is from 3 to 14%. It varies widely across the sources. It depends on the definition of contrast-induced AKI that is used. It depends on the type of patients that are included in the studies, but grossly, it's 3 to 14% of patients after coronary angiogram or PCI that have contrast-induced AKI. This is not a benign complication, as we know it has been documented very extensively that contrast-induced AKI is associated with increase in hospital length of stay, dialysis, bleeding, MACE, ischemic outcomes as well, and obviously costs. Despite this, there's nothing much we know about how to prevent that. We know for sure that decreasing the amount of contrast given during a coronary angiogram, well, obviously it decreases the risk of contrast-induced AKI, and also that using IV hydration, it decreases the risk of contrast-induced AKI. These are the two only known preventive intervention that we can do to prevent this. However, I'm sorry, another tree fall in my backyard. Everything's fine. However, there's a knowledge gap. Yeah, we know that we need to give IV hydration to patients to prevent that before, during, and after the procedure, but we don't know how much. And if we ask 10 or 100 interventional cardiologists, everyone has his or her own recipe. Some of them give IV hydration 12 hours before, 12 hours after, some only during a procedure and after, and so on. There's no what I can say standard recipe. There is one good randomized trial, that the Poseidon trial, that evaluated if that could be beneficial to tailor the IV hydration to some key patient characteristics. So the Poseidon trial was published in The Lancet in 2014. It's a relatively small trial, 400 patients with a GFR under 60 who underwent coronary angiography. Participants were randomized to either the experimental group. In the experimental group, the normal saline, so the hydration rate, was adjusted to the patient volemic status as measured by LV and diastolic pressure. So at the beginning of the procedure, LV diastolic pressure was measured. There was a standard algorithm in the study, and if the LV-EDP was high, patients will receive less hydration. If the LV-EDP was low, patients were receiving more hydration. That's the experimental group. In the control group, everybody received the same amount of fluid, so 1.5 cc per kilogram per hour, which is a standard hydration rate that we use. And the primary endpoint was well, actually, the study was very positive. The study was very positive. The primary endpoint was AKI, 6% in the experimental group, 16% in the control group. So quite a large absolute 10% difference. If you look at on the right on the Kaplan-Meier curves, the secondary endpoint of the composite of death, MI, or dialysis was also very substantially reduced by the tailored hydration therapy based on LV-EDP alone. However, the Poseidon strategy of tailored hydration by LV-EDP was not much adopted in clinical practice, and it was not included in subsequent clinical practice guidelines. So there were guidelines by the AHA and by the SCAI, the Society of Coronary Angiography and Intervention, that were published afterwards. They did not include the Poseidon strategy for many reasons. I think that mostly it was because the eligibility criteria were quite stringent. So 75% of patients who were approached were not eligible. So they really focused on a very selected type of patient population, and it's difficult for us in clinical practice to understand whether our patient would have fit in the Poseidon trial or not. There's also a high loss to follow-up, 12%. And also, and this is only my hypothesis, it has not been verified, but I think that the Poseidon strategy has not been well adopted in clinical practice because the two main drivers of acute kidney injury are baseline renal function and the amount of contrast delivered. And these were not addressed by the Poseidon strategy. And in real life, a patient to whom we give more contrast, or a patient who has very low baseline renal function, well, we tend to give them more hydration, regardless of LV-EDP, to prevent contrast-induced AKI. The fact that the contrast volume and that baseline renal function are main drivers of contrast-induced AKI has been very, very well documented. I show you one study among others here. So this is a study from the US, registry observational study, including close to 60,000 patients who underwent PCI. And the authors classified the patients according to their baseline ratio of, so the CV on CCC ratio is a contrast volume divided by creatinine clearance ratio. So for patients with a ratio under 2, the risk of CI-AKI was low, was less than 2%. For patients in the middle, in light blue, with a ratio between 2 and 3, the risk was still around 3%. But as soon as you go over 3, a ratio over 3, well, the risk of CI-AKI really increases substantially. On the top panel is for CI-AKI, and the lower panel is for requirement for dialysis. As I said again, in the clinical guidelines, it is recommended to use IV hydration, but it is not recommended to tailor the hydration based on the contrast volume creatinine clearance ratio. The guidelines say that it's useful to calculate this ratio to predict the risk of renal injury, but they don't say, hey, you should tailor the IV hydration based on this ratio, probably because it just has never been studied. So this is all the background you need to know to understand the rationale underlying the need for the Poseidon trial. So I'll just read it out loud. There's a clear unmet need to identify pragmatic and easy to apply strategy tailored to the most important drivers of CI-AKI, amount of contrast, baseline renal function, to prevent renal complications in patient-oriented clinical endpoints in all comer patients undergoing coronary catheterization. So this is the NEPTUNE trial. The trial has been launched. It's a multi-center trial. It has been launched at the Montreal Heart Institute in June 2021. There was a pilot phase at that time. And the primary objective is to evaluate the effectiveness of a hydration strategy tailored to LVEDP, baseline renal function, and the amount of contrast to reduce the risk of CI-AKI compared to a non-tailored hydration strategy. The primary objective is to look in all comer patients, so everybody coming to the cath lab, and also to the high-risk subgroup of patients with decreased eGFR. Study is powered for both. So we designed a pragmatic multi-center randomized trial. It's in 3 provinces of Canada until now. We are looking for 1,100 patients. We have randomized 320 so far. And we are aiming for close to 400 patients with a GFR under 60. There are secondary objectives. The secondary objectives are to look at the effectiveness of the strategy on rate of major adverse renal and cardiovascular events, so not only CI-AKI. And we also want to see if there's an effect of the tailored strategy on the risk of persistent kidney damage on the long term. So we debated a lot on how to which study population we wanted to include in the Poseidon trial. The point of this study was to be able to for its result to be generalizable to the largest number of patients that come to the cath lab in real life, in the real world. So we really wanted to minimize the number of eligibility criteria. So we have only 4 inclusion criteria. So patients need to be adult, they need to have a planned coronary angiogram, and actually to be willing to participate, and that we think that are not going to die within the next 6 months. So basically, a vast majority of patients coming to the cath lab. Exclusion criteria, we try to keep them to a minimum. We only included exclusion criteria for which we thought that it was either unsafe, unrealistic, or unfeasible to administer the intervention, the experimental strategy. So basically, we excluded patients in shock, patients who require emergent cath, patients who had a cardiac arrest, patients who have an active AKI. Obviously, there's no point of including them. And patients, the 2 last exclusion criteria, severe aortic or mitral disease and severely depressed LVEF, it's because of discussions with the IRB, we thought that it would be unsafe to include these patients and expose them to a high quantity of IV hydration. So I won't go through this in details because it's not really the point of the presentation, but just to show you that we have a very strict algorithm to follow if you're randomized to the experimental group. So if you're randomized to the experimental group, the LV and diastolic pressure is measured at the beginning of the procedure. And according to the value, well, the hydration rate can be from 1.5 to 5 milliliters per kilogram per hour during the procedure or for 1 hour. And for the 4 next hours, the hydration rate will be adjusted according to the contrast volume on eGFR ratio. Primary endpoint, as I said, is AKI in the total cohort and also AKI in the CKD subgroup. The study is powered for both. I'm going to talk about it a little bit later. We have secondary endpoint that I mentioned already. So the composite of death, MI, stroke, or renal replacement therapy at 6 months. We're looking at chronic kidney disease at 6 months and hospital length of stay as well. So far, as I said, we had 320 participants enrolled since June 2021. We have 5 active sites, including 4 in Quebec and 1 in Ontario. We have 3 recently activated sites that are going to start randomizing in 2023. The CHIM, the Thunder Bay Hospital, and the Winnipeg St. Boniface Hospital. So I said that we call that a pragmatic trial. So I'm just gonna do a short capsule on what is a pragmatic trial, how I see that, and why we thought it was important to include pragmatic elements in the NEPTUNE trial. Obviously, this is not this is going to be quite a superficial overview of pragmatic trials. We can talk about this for hours. But there's a lot of variability in how people define and think of what a pragmatic trial is. We often hear that a pragmatic trial is a study that included streamlined study processes to improve the efficiency of study operations, facilitate participant recruitment, and minimize costs. We often hear that, but I would posit that this is not really what a pragmatic trial is. A pragmatic trial can or cannot use streamlined operations to facilitate the study operations, but really the main purpose of a pragmatic trial is not focused on the way the operations are made, but on the way on the type of question the study is going to answer rather than on the operations. And to understand more properly where that comes from, it can be useful to look at the first paper in which actually pragmatic attitudes and pragmatic trial was described. It has not been for a long time. It was in 2009 by Schwartz and Lelouch, who for the first time raised the concept of explanatory trials versus pragmatic trials. And it's easier to understand what a pragmatic trial is by comparing it to what an explanatory trial is. So if we go row by row, an explanatory trial is aimed at understanding a biological concept. It's not aimed to change practice. A pragmatic trial is aimed at supporting a clinical decision. Row number 2, the question answered by an explanatory trial is there a difference between two treatments which are specified by strict and usually simple definitions? However, a pragmatic trial is which of the two treatments should be preferred. So again, the answer to a pragmatic trial is really aimed to guide decision-making and to direct clinical applicability. In explanatory trials, the participants are usually a group that is as likely as possible to reveal a treatment effect. So we want to show that the new treatment is associated with a specific treatment effect. So we select a group of patients that are very highly likely to respond. In a pragmatic trial, the participants are the patients to which the results will be extrapolated in real life. And finally, in an explanatory trial, the endpoints are biologically meaningful criteria, for example, a blood test or, I don't know, a radiology test and so on. In a pragmatic trial, the endpoints are usually endpoints that are more patient-driven or health system-driven, not all the time, but usually. So just in a nutshell, a pragmatic trial is a trial in which the study procedures deviate as little as possible from routine clinical care, except for the studied intervention. So a purely perfect pragmatic trial would be a trial in which the patient's trajectory in the system of care is identical to what it would be if the patient was not randomized in the study, except for the study intervention. So I'm talking about no additional study visits, no additional blood samples, no additional stuff. It's aimed to be directly inform decision making in an easy way, and again, it's aimed to be designed in a way when the trial is completed, immediately and very easily you can use the result in your broad clinical practice in a large majority of patients with a disease, not only in a subgroup. I could go with an example of what an explanatory trial versus a pragmatic trial would be for the same question. This is all hypothetical. Let's say we want to test if aspirin works in primary prevention of cardiovascular disease. If we want to answer that using an explanatory trial, well, we want to make sure that we put all the chances on our side to prove a concept that aspirin works. So the patients, the participants of the study, well, in this hypothetical study, we would take the patients more than 65 years old with diabetes and very strict eligibility criteria, maybe enrichment criteria, making them higher risk. And we would do a massive marketing process in which, well, we would try to reach out for patients from everywhere, from their home, through the medias and so on. And some patients are going to call you and going to have a lot of patients to be enrolled in your study. The follow-up will be very frequent. Patients are going to come frequently, let's say every 3 months or every 6 months, to see the study team, to evaluate the compliance, to make sure patients take their aspirin or the placebo very every day, to evaluate safety and endpoints. And we want to make sure during follow-up that all the concomitant medical therapy is optimized. I mean by that every patient will be on optimized lipid lowering therapy, hypertension therapy, and so on and so on. The primary endpoint would be aspirin inhibition as measured by light transmission aggregometry. We want to make sure that it's a very objective endpoint that is not very prone to measurement errors or to variability or to subjectivity. Secondary endpoints will be exploratory clinical endpoints. So the conclusion of an explanatory trial on aspirin primary prevention could be read like this. I'm just going to read it out loud. So in this specific population of high-risk patients who responded to research advertisement with near perfect compliance, frequent contacts with study team, and careful optimization of concomitant medical therapy, aspirin improves platelet inhibition and may improve clinical outcomes. So that's very nice. That's super useful. That's very hypothesis generating. But when reading this, can a clinician say, oh, I will start using aspirin in all my patients and do nothing different and that will work? Probably not. So an explanatory trial is super useful, but it depends again on the question you want to ask. When you read this conclusion, well, one can be tempted to say, okay, right, I'm going to confirm that in a pragmatic trial. It's a pragmatic trial evaluating kind of similar clinical question, aspirin primary prevention. So this time you want to make sure that the results apply to most of your patients. So you take patients, again, 65 years old and with diabetes, you don't add enrichment criteria, and you identify them in their real world primary care clinics. So you don't have a selection bias. You really take the patients in your clinic to which you would offer the drug usually. The follow-up is not as frequent. You try to minimize the contact of the patient with the study personnel. You query the medical chart, you call the patients if necessary, if an event comes up in the medical chart. There is no specific reinforcement of the compliance and of concomitant treatment, just as it would be if you would prescribe aspirin to your patient in the real world. The primary endpoint will be a clinical endpoint that is selected by patients and the physicians, so an endpoint that is meaningful for the most important stakeholders. And the conclusion of this study would be that in a real world, all-comer elderly patients with diabetes, adding aspirin to usual therapy improves clinical outcomes that are meaningful for patients. So you see, the same clinical question answered by two different types of studies and study designs may have different implications. To guide us to, if we're interested in designing a pragmatic trial, to guide us, there's this very useful tool. It's called the pragmatic wheel, the PRECISE2 wheel, in which 9 domains of a protocol design can be considered to integrate pragmatic or explanatory components. So not all trials are purely pragmatic, not all trials are purely explanatory. Some trials may be 50-50. It depends on the domains. When I talk about the domains is recruitment, the setting in which the study is done. Maybe a trial would be super pragmatic in terms of recruitment, but in the setting or in the organization or in delivery, it's going to be more explanatory. There are pros and cons for each choice, obviously. So just a few words on the NEPTUNE. I used the PRECISE2 wheel, and for some domains of the design in NEPTUNE were more pragmatic and some were more explanatory. So for instance, for eligibility, we use very few eligibility criteria. We excluded mainly patients to whom it would not be practical to administer the tailored hydration therapy in real life. So we aim to have a very pragmatic eligibility criteria to improve external generalizability. In the domain of recruitment and setting, we have not done any advertisement. We have not, we don't wait for the patients to reach out to us. We go reach the patient. We approach them in their routine clinical environment. So basically, we go see patients before they're CAT, and this is where we randomize them. So that's pretty pragmatic. For the organization, there is no specific expertise or resource that is required to deliver the intervention. We don't need people who are very expert in something. It's not very complicated. Every cath lab nurse can change the rate of hydration in the cath lab. So this is not complex. It's easy to apply in routine. For flexibility in delivery and adherence, well, for this domain, we are not pragmatic at all. So for this particular thing, we are mostly on the explanatory side, and this is a choice we made. We make sure that the research nurse stays during the procedure to make sure the algorithm of tailored therapy is followed very strictly, which will not happen in routine care. There's not going to be a research nurse every time a patient goes into the cath lab. So we decided in this particular study to be very strict on adherence, and this is not pragmatic. This is more explanatory. Follow-up. The follow-up in NEPTUNE, we don't follow patients more than usual. We do a creatinine and we call them for a clinical follow-up 48 hours, 7 days, and 6 months after the CAT. We could argue that these could be clinically indicated and done in mostly of the patients, usually in clinical care after a CAT. And finally, for the primary outcome, we use contrast-induced AKI. It is not much. Well, I don't think it's an endpoint that is much patient-oriented. It's an endpoint that is commonly used in these type of trials, but one could argue that asymptomatic and self-resolving contrast-induced AKI is not very meaningful for the patient and the patient trajectory. So we wanted to be more practical. We used an endpoint that was easy and it's explanatory, easy and well accepted in the scientific literature. So we are more explanatory here than pragmatic. But I'm going to talk later about the endpoint in NEPTUNE and how we're going to address that. So patient-oriented trials, again, this really is a buzzword. Everybody talks about patient-oriented trials, and I think for good reasons. There's no standard definition of what a patient-oriented trial is. Basically, what that means is that we involve patient partners in one or multiple components of the design or operations of the study. So patient partners can be involved in the selection of the endpoint of the trial, in the design of study procedures, in patient recruitment. You can have patients who go see other patients to randomize them in the trial. Patient partners who can help in participant retention, data dissemination at the end of the trial, and so on and so on. Why is that important? There are many reasons to involve patients in the design and operations of a study. I enumerate the four that I think are the most important. The first and foremost, patients' viewpoints on how the therapy should impact them are often not aligned with clinicians and trialists. That means that it has been documented, it has been studied. When you test a new drug or a new device, for example, and you're a trialist, you decide with the FDA or with Health Canada that the primary endpoint of your trial to decide if the treatment has some efficacy is going to be this. But if you ask patients, and even if you ask clinicians that are not trialists, they will say something else. So it really is a misalignment here that could be very interesting to explore in every trial we do. Why involve the patient? Point 2 and 3, it has been showed over and over again that if you involve patient in the operations and the design of the protocol, it facilitates recruitment and it facilitates patient retention, less loss to follow-up. It's also cost effective for partly for this reason. Involving patients can be a little bit more costly because most of the time you need to pay your patient partners or you have to organize and the meetings and so on. It takes time, but in the end, it's usually cost effective. There you go. A few examples of how patients can, of how a study can be quote unquote called patient oriented. I picked up this one because it received a lot of press when it came out. It's called the ASPRI trial. It was published in 2018. Maybe some of you heard about it. It's a large randomized trial published in the New England Journal of Medicine, looking at the effect of aspirin in primary prevention in healthy elderly. So a very simple design. Patients over 65 years old were randomized to aspirin or placebo. Patients without previous cardiovascular disease. But the main highlight here is that as opposed to most of the large cardiovascular trials, the primary endpoint was not a MACE endpoint, was not a major adverse cardiovascular event endpoint. It was disability-free survival. So on the left side here, primary endpoint was a composite of death, dementia, or persistent physical disability. Not as much because the investigators thought that aspirin could be a strong agent to prevent persistent physical disability, but because they thought, hey, what's the point for patients to prescribe them a drug if it's not associated with a significant improvement of persistent physical disability in this category of patients? The trial was neutral, so it showed that aspirin was not useful for this purpose. On the right side, they also evaluated the standard MACE endpoint as a secondary endpoint, was also not statistically significant. But the study was powered for patient-oriented endpoint and not the standard cardiovascular endpoint. There's also, I talk a lot about aspirin because this is my main focus area of research. There was also a large trial published in 2021, the adaptable trial. I was very happy to be involved in this trial. This study was a study in secondary prevention of atherosclerotic cardiovascular disease. And the main objective was to evaluate whether aspirin 81 milligram or aspirin 325 milligram was superior in the secondary prevention of atherosclerotic cardiovascular disease. So 15,000 participants randomized to either dose. And the study was neutral. There was no difference between two groups. But the point I want to raise here is not that. The point I want to raise is that in this study, they made a lot of efforts to include patients in the study leadership. So patients were from the onset involved in the protocol design and in the operations of the study. There were 9 patient partners, patients with a lived experience of the disease, who were paid to be in a committee. These patients were called the adapters because they were in the adaptable trial. They met twice a month. They reviewed the progress of the trial, and they made recommendations to the executive committee on how to make the trial more patient-oriented. 2 patient partners were part of the executive committee. Some were part of the steering committee as well. Through the trial, they developed recruitment and retention material. At some point during the trial, recruitment was slower, so patient partners came up and developed recruitment materials, and that worked. At the end of the trial, the patient partners disseminated the trial results to the adaptable community, so all the study participants, but also to the lay community overall. Here are the adapters, so they were very involved. There was a big community of patients in the trial, and it contributed to create a feeling of belonging in the trial for all the participants. In NEPTUNE, I try to integrate them as much as possible patient-oriented components in the study for all the reasons I just said. It's a low budget study for now, but we applied to grants, and if we are successful, we're going to include patient partners that we're going to be able to pay to be part of the steering committee, the executive committee. So for now, what we do, as I said, we are looking at the study intervention improves the risk of the primary endpoint, contrast-induced AKI. As I said, it's a commonly accepted endpoint, contrast-induced AKI, but my feeling, I don't know, but my feeling, it's not very meaningful for the patients. So we are currently developing a patient-oriented outcome in the form of a survey. So I have a master's student who is developing a survey, and the purpose of this survey to patients is to find what are the preferences of patients undergoing a cath lab regarding their renal outcomes. And at the end of this survey, we're going to be able to find an endpoint about renal outcomes in this study that is going to be decided by and for the patients. So 200 patients are going to be surveyed. We're also going to survey 20 to 30 doctors who take care of these patients, just to explore if the preferences regarding renal outcomes are similar or not between patients and their doctors. So it's going to be kind of interesting. So I just said that. How much time do I have left? Okay, a bit of time. Adaptive trial. I don't want to spend too much time on that because it can be there's a lot of things to say about adaptive trials too. You know, we could talk about that for hours and hours, and this is really a brief overview. So again, it's easier to understand what is an adaptive trial when we compare to what is a classic trial. So with a classic trial, we write a protocol, and in the protocol, we pre-specified all components of the protocol that are fixed, that are not going to change until the end of the trial. So we have a fixed eligibility criteria, fixed sample size, fixed follow-up duration, and unalterable endpoint. So we have an endpoint at the beginning, is going to be the same at the end of the trial. However, when we write the protocol, we have to guess about a bunch of stuff that we likely don't know. So when we write a protocol, we have to know what will be the absolute event rate. So we rely on previous data from other studies that were made on kind of the same patient population, but not exactly the same patient population. We have to guess what will be the treatment effect. But you know, most of the time when we do a trial, we don't know what the treatment effect was going to be. Otherwise, we don't need a trial. So you have to guess that. You have to guess which will be the most promising target patient population. You have to guess what will be the loss to follow-up rate. You have to guess a bunch of stuff, and most of the time we are wrong in our guesses. And if we do a classic trial, when we stick to what we decided at the beginning, well, the trial could be neutral or could be negative, not because the treatment doesn't work, it's just because we had incorrect assumptions at the beginning. And this is the interest of adaptive trials. It allows us to change some elements of the protocol without altering the integrity or the scientific validity of the findings. There is no standard definition of what an adaptive trial is. It could be very heterogeneous across the literature, but I will just show you what the FDA think, how the FDA defines an adaptive trial in their document to industry, the guidance document to industry. So I'm just going to read it out loud. An adaptive trial design is defined as a clinical trial design that allows for prospectively planned modifications to one or more aspects of the design based on accumulating data from subjects in the trial. So I highlight here that it's a prospectively planned modification to the design. You need to think about it early on. You cannot finish or in the middle of the trial say, hey, why don't we change this and that element of the protocol? That wouldn't be fair. That wouldn't be, and that wouldn't be ethical or scientifically valid. Many types of adaptive designs. Some trials can integrate seamless expansion from a pilot to confirmatory trial. This is what we did in NEPTUNE. So initially we started NEPTUNE as a pilot trial. We attained our pilot objectives, and that allowed us to seamlessly continue the trial, combining the data from the pilot phase to the confirmatory phase, if I can say, and we could leverage operational continuity. So by that I mean we use the same CRF, the same study procedure, the same coordinating center, and so on. We didn't have to do a pilot trial, stop it, and start a new confirmatory trial, losing all the data and using a different infrastructure. So that can be called an adaptive design. The most frequent type of adaptive design that we see in large-scale randomized trial, at least in cardiology, is sample size re-estimation. We see that quite often. In the course of the trial, we can look either blindly or unblindly, and we can look at the data aggregated or non-aggregated. By that I mean comparative data between two treatment groups or the whole, the totality of the event rates, and we can re-estimate the sample size. Obviously, we need to do that carefully with good statisticians. Another type of adaptive design is population enrichment design. So that means that if you run the trial and after a while you realize that the specific subgroup doesn't seem to respond well to the treatment, you can drop the subgroup, change the eligibility criteria to include patients who are more likely to respond to the treatment. And again, I come back to this very often. You cannot do that without having thought about it prospectively. You need to pre-specify at some point in the trial, at 50%, for example, of the trial, we can reassess if it's worthy to include this subgroup or not. You cannot just cherry pick while you're doing the trial. So you need to do that very carefully. Other types of adaptive designs, many types are not written there, but you can change the randomization ratio. You can even change the primary endpoint. You can pre-specify stopping rules for futility or for overwhelming benefit, for example. Just an example of how a trial could be considered adaptive. You may have heard of the ischemia trial, a very important trial published in 2020 in the New England Journal of Medicine. So in this trial, 5,000 patients with stable coronary disease and moderate to severe ischemia on non-invasive tests were randomized to either conservative therapy or to an invasive strategy, so a coronary angiography with or without revascularization. The study was neutral once again, but it's not the point. There were very complicated statistical issues with the study. I won't go into that today, but the point is that the primary composite outcome was a 5-point MACE outcome that has been changed in the course of the trial. On the left panel, on the right panel, you see the outcome of death from cardiovascular death, CV death or MI. This was a secondary outcome when the authors presented that in the final New England paper, but this was the original primary endpoint. So how did they do that? We don't see that often, but I think that the ischemia investigators did it quite properly. They did it in a perfect way to make sure this did not alter the scientific integrity of the finding. So initially, their primary endpoint was CV death or MI. The change was pre-specified in the protocol at the beginning. So the investigators in their protocol wrote, "Hey, at some time in the trial, I can't remember if it's 50% or I think it's with less than 50% 50% of participants included, we have the right to look at the aggregated event rate and to change the primary endpoint for CV death, MI, hospitalization, and so on. If this happens, it needs to be done by an independent advisory panel. The study leads and the study executive committee did not have access to the data and were not involved in this decision. So it was done properly. This is what happened. The aggregated event rate was lower than anticipated. So the independent advisory panel looked at the data and said, "Hey, In your protocol, you say you can pre-specify, you can change back to this 5-point Mason point as a primary endpoint, and this is what they did. It's a pretty elegant there. There was a lot of discussion in the press about that. There are pros and cons of doing that, obviously. So very important key considerations for adaptive designs. It really needs to be pre-specified. Again, I said it many times, but it shouldn't be based on accumulated evidence on an unplanned way. You cannot just say at some point, hey, let's change the primary endpoint, and you have not pre-specified it. It's not valid. The rules need to be clearly formulated. If you want to change the eligibility criteria, for example, or stop early or whatsoever, you need to establish pre-specified rules on which grounds you're going to do that. You cannot come up with them in the middle of the trial. And most of the time, it's recommended that these changes in the protocol must be recommended by independent authorities, usually the SMB, but it can be another kind of independent panel, and not by the executive committee or the main trial leaders. I'll just skip that sake of time, but it's just I'm saying that there are some ethical and scientific advantages for adaptive designs, mostly to make sure the trial really is able to answer the scientific question it's aiming to answer without compromising scientific integrity. And there are limitations. It's more complicated. It's really more complicated. You need to have very good statisticians. They're going to think of all the scenarios and prepare scenarios for everything that can happen. You most of the time need to do more frequent analysis, so pre-specified interim analysis, and it can be more costly. Again, it needs to be carefully planned from the onset. And it requires independent committees, as I said, to maintain scientific integrity, and that can be a bit more costly if you want to have a DSMB or any other type of independent committee looking at the data. There are some few adaptive components to NEPTUNE. As I said, it started as a feasibility phase, and we seamlessly transitioned to the confirmatory phase in an operationally seamless way. We pre-specified a re-estimation of sample size. So when 75% of the study sample will have been randomized, the SMB will look at the aggregated total event rate, not the comparative, but the aggregated total event rate, and as well as the loss to follow-up rate. And the SMB will do recommendation on the re-estimation of the sample size. And we're going to add a secondary endpoint. So the patient-oriented endpoint that I've discussed earlier on will be added at a secondary endpoint. This has been pre-specified. So in the protocol from the onset, we say, hey, we're going to add a patient-oriented endpoint. We didn't specify what will be this endpoint because we have not developed it yet, but we're in the process of developing it, and we're going to use that. That's it. So in conclusion, a few key points. Pragmatic trials are useful to support decision-making more than explanatory trials. Most trials have pragmatic design components and explanatory design components. Patient-oriented designs allow to generate study results that are more meaningful to the main stakeholders, and it can facilitate study operations as well, but not necessarily. Adaptive trials improve flexibility in the design, but it must be well planned prospectively to ensure the research integrity. So I'm going to stop there. Thank you. We'll be ready for any question if there is any question.
Great, Guillaume. Thank you so much for your talk here. I really appreciated how you both highlighted your trial and then some key sort of innovative aspects of new trial design and link that back to your trial as sort of pragmatic or as practical examples. So I think that was very, very helpful. Kabiri, I see your hand up. I don't know if that's you or someone else in the room with their hand up.
No, it's me. I first of all, I wanted to say that what a beautiful presentation. Really, really, really nice. And as Abhinav says, integrating the methodology with the trial that you're conducting, I think it's fantastic. I have a couple of, these adaptive designs, they're hard if you've ever been a purist, because you always feel like you're changing the rules of the game. And is there a risk of changing the rules of the game that will kind of favor an outcome that you want. And I appreciate that, you know, you're saying that things are pre-specified, but first of all, I think this can only work if you have a study with thousands of patients, no? Because if it's a small, if you don't go beyond a certain number, you probably will not have the power to tolerate removing a subgroup, for example, or, you know, could you comment on that? Are there some frameworks or concepts to keep in mind in terms of which situation could you reasonably have, you know, an adaptive trial? Because I think the risk is someone will come in with a study of 100 people and try to have an adaptive trial, and I'm not sure that is a valid thing.
So the first example that comes to mind, so the answer is yes, that adaptive components can be used for studies from small scale to large scale studies, but not all of them are suited for all types of studies. And the first example that comes to my mind is phase 2 trials, those searching trials, for example. You know, there's a new drug and you want to see if it works. And the primary endpoint is the biological response. You do a blood sample and you measure if there is a biological response to the new drug, but you don't know which dose is the best. So you have a randomization ratio of 3. So 1 out of 3 patients are placebo. The first experimental group has dose of 100 for to say something, and the other arm has a dose of 1,000 milligram daily. And you can pre-specify in your protocol. Well, we're going to start, and after, I don't know, 50% of the patients are randomized. If we see that the dose of 100 milligram daily doesn't work, we're just going to drop this arm, and we're just going to continue with the arm that seems to work. So in those findings studies, that can be very, very suited to do this type of thing, or not necessarily dropping an arm, but adapting the randomization ratio. It has been done very, very often in the past. So instead of a 1-1-1 ratio, it can be a 1-1-2 ratio, and you increase it, and you increase the number of patients who seem to get the dose that seems to work. It has been done in the past. You have to do it very carefully. You have to have a good statistician again. And there are many ways to adapt a trial, not only through the change of the primary endpoint as they did in ischemia.
I actually understand the dropping of a group more than I understand changing the ratio, because it feels like if you're changing the ratio because you've kind of lost equipoise, I'm not like, that seems odd to me. You're kind of stacking it against also something that you think is not as good anyway. So that one I have trouble with. Yeah.
So I'm not a statistical expert in the methods on how you do that, but I have seen that in the past in a Bayesian study. So in a Bayesian study, the initial ratio was 1-1-1, for example, and as soon as the data accrued, we're talking about another topic. Obviously, Bayesian analysis is different from a frequentist analysis, but as the data accrued, there was one treatment arm that seemed to be more effective. So patients who were randomized later on in the trial were more likely to be in the effective arm than in the non-effective arm, if I can say. So that increased the power to identify a significant treatment effect with a more promising dose, if I can say. But you know, you have to have very good methodologists with you when you design this type of trial.
I think Sasha has a couple of questions. So thank you.
Great. Sorry, I don't see any other hands up, but if there are any other questions, please feel free. I see some chats in the comments here, Sasha. I'll just read it out here. Love your presentation. Oh, Sasha, you're there. Perfect. Do you have would you be able to sort of verbally ask your question?
Well, you know, when I was, thank you so much. It was really practical and helpful for people who are, you know, maybe, you know, hopefully using this kind of methodology in the near future. So then my question, what relates to this, the fact that as clinicians, we may feel that something is clinically relevant, but it means nothing. Like, for example, if we say doubling in creatinine is obviously clinically significant because we know what follows after, but to a patient, like doubling creatinine means nothing because it's just a number. However, could you translate that so that you keep the clinical community and the physician and the patients happy, such that whatever's clinically meaningful to the clinician is translated for the patients in terms of how it would impact them in real life? Like you may increase your chance of needing dialysis by 10% or something like that. Any thoughts on that?
So you know, I have not been an investigator for a long, but most of the trials I've been involved in included patients in the executive committee and in the leadership, and it's humbling to realize how much you know, we don't speak the same language, obviously, and we can try to convince patients, hey, you know, increasing creatinine is not good because it can lead to this and that and this and that, and you know, in the end, they don't really care. They just really don't care about this. And then to answer, there's no perfect answer to your question. The thing I would say, if this is what I do, I'm designing the trial, I'm designing the NEPTUNE trial, and I just sit down with patients and hear their voice, hear what they want to, what they have to say, try to have as a diverse range of patients as possible. I don't want to just sit with patients who have PhDs. That's not useful.
Mm-hmm.
And you know, I would love to bring a pinpoint answer to your question, but it's just so different regarding on types of patients and types of questions you are trying to ask.
Thank you.
Answer. Yeah,
Thank you.
sure.
Great. And so I have a question, Guillaume, with regards to, I know we're right on the time here, but maybe can you just walk us through just in a minute your consenting process for these pragmatic trials? You know, there's also the component of embedding sort of very simplified consent processes, but I know, you know, different REBs have their own approaches. Is there a simplified consent form or consent process that you're leveraging, or is it the standard one patient, one consent, they have to go through the whole ICF, they need to take time to read it? Like, is it the same sort of consent process compared to some of the other models that we've seen, you know, with the SWEET trial, for example, that was done, you know, in Europe, where they did the thrombectomy, where they had a very, very short consent process. It was done on the spot, and then they sort of moved on. Maybe can you walk us through that?
So there's a lot of work to be done in this field. That's interesting you asking this question, because in the adaptable that I spoke about, we published a paper that dilated about streamlining the informed consent for patients in pragmatic trial, and giving the example of the adaptable trial. And in the adaptable trial, what we did is that you know, I didn't, but the adaptable team developed a very nice video with cartoons. This is the study. Aspirin it prevents heart attacks, and you see the patient with a cartoon. You can be randomized to 81 milligram and 25 milligram, and the cartoon goes to study visits and so on and so on. But in the end, it was useful for the patient to understand the study, but IRBs are not there yet, and IRBs need a full series of language with all the data required. You know, these are the risks, this is how it's going to happen, blah, 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 blah. 10 pages consent, and we move away from being pragmatic. And it's not because of the researchers, it's not because the patient partners think that, oh, we really need a 10-page ICF, that's what we want. It's really is the RB who want that. So this is very challenging. I haven't heard of any IRBs who were agreeable of having more streamlined consent forms. But you know, if us as researchers, and if patient put forward that a 10-page consent form is not useful and they don't read it anyway, maybe with time we can be able to change that, but we're not there yet.
Okay, that's amazing. And so we're just a little bit more past the top of the hour. So Guillaume, thank you so much for your time. I certainly learned a lot with regards to how you've been implementing your novel trials. And perhaps when the results of either your initial phases or your other phases are ready, we'd love to have you back so that we can learn from how this process has gone and learn about the strategies that you've done to make our trials more accessible, more efficient, and answer patient-relevant outcomes. So thank you very much for your time.
Sure.
Thank you everyone for attending.
Thanks for having us. Bye. Bye, everyone.